the executive members of CHILD NEUROLOGY Society of Nigeria, ably led by the moderator of the day, Dr. Edwin Esegbe, the presenters, Dr. Chimaeze Totti and Dr. Lami Gidado, PAN elders in the room, esteemed PAN members, both at home and abroad. Good afternoon and welcome to PAN's webinar in the month of October 2025. We're grateful to God for the past 9 successful webinars in 2025. In line with one of our core values in PAN, which is lifelong learning, we gather once again to learn. Today's session is dedicated to an important topic, learning disabilities in childhood. As pediatricians and child health advocates, we are acutely aware that every child deserves the opportunity to reach their full potential. Learning disabilities, though often invisible, represent a major barrier to educational achievement, social integration, and emotional well-being. Early identification and effective management are therefore essential components of holistic child care. Unfortunately, we live in a society where some families view learning difficulties as spiritual problems, causes, or moral failures, which delays diagnosis and intervention. On the other hand, we know that every child can learn, but not in the same way or on the same day. My sincere appreciation goes to the Child Neurology Society of Nigeria for bringing this up and putting this webinar together, and to every participant in the room. Let's be an active part of this learning experience by asking questions, sharing insights that can help improve the quality of life and learning for every Nigerian child. Thank you very much.
So we now hand over to the moderator for the day, the president of the Child Neurological Society of Nigeria, Dr. Edwin Esegbe. So you can go on.
Thank you very much, Madam President-elect, Madam President of PAN, distinguished elders and colleagues. On behalf of PAN and the Child Neurology Society of Nigeria, I welcome each and every one of us to this PAN webinar on learning disabilities in childhood. As has been stated, it's something that is becoming of increasing public interest. Reports indicate that up to 1/5, and in some cases a quarter of Nigerian school-age children have learning disabilities. To discuss this topic and to do justice to this topic today, we have 2 speakers. One of them, Dr. Chimaeze Totti, is a senior lecturer in pediatrics. He's a pediatric neurologist at the University of Calabar Teaching Hospital. And then we have Lami Gidado, a certified play therapist, a special educationist, and founder of the Association of Play Therapy in Nigeria. We'll be looking at various aspects of learning disabilities in childhood, and I'm sure we'll have a lot to learn, and there'll be a lot of questions to ask, and I'm looking forward to an exciting meeting. Without further ado, I would yield the floor to Dr. Chimaeze Totti, who will start off this presentation. Thank you very much. Dr. Totti.
Thank you very much, Prof, for that introduction. Good afternoon, distinguished pediatricians. I'm glad to greet you today from the coastal city of Calabar. Today we'll be discussing a very interesting topic. Is my slide moving?
Not yet. It's still not moving.
Yes. Okay.
It is now.
Yes. Yeah, I work in University of Calabar and the University of Calabar Teaching Hospital. Calabar, we say, come and live and be at rest. You can do that at your leisure.
Fine. Thank you so much. Thank you. Thank you. Thank you.
You can see the outline of today's presentation will be, and the learning objectives will be first to define and differentiate learning disabilities, identify common types of learning disabilities in childhood, describe the neurobiology of specific learning disabilities across different age groups, explain the diagnostic criteria and assessment tools, then define the role of the pediatrician in the care of these patients, of these special needs children. Learning is one of the most important human activities and is said to be as old as mankind. It starts soon after birth when the child learns parents' language and objects around him. Today, academic achievement serves as the yardstick for measuring individual success and potential, and it tells the level of success a person has attained in educational pursuits, including assessment in grades, test scores, and overall performance. However, some pupils may have difficulty with reading, writing, or spelling, and may struggle to adapt to the formal educational system because it's often designed with the assumption that all pupils will naturally acquire these basic skills. And these difficulties are not related to intelligence or lack of effort, but rather a neurological condition that affects the way the brain functions and processes information. So learning disorder or disability, as the case may be, is a neurodevelopmental disorder characterized by persistent difficulties in learning key academic skills, including reading, writing, or mathematics. These that are not consistent with the individual's chronological age, educational opportunities, or intellectual abilities. This is according to the American Psychological Association. They affect an individual's ability to process, interpret, or respond to information in a typical manner. Children learn to read at different paces, and it's normal for them to struggle at some point. But if a child seems particularly frustrated with reading and writing or math over an extended period of time, there's a chance he may have a learning disorder. And these difficulties, we need to note, often cause problems that impact their daily activities and social interactions. Typically, these disorders are diagnosed in the early school age, although they may not be recognized until adulthood. And it's worth knowing that it's a lifetime condition that impacts all aspects of life, socially, academically, and other life achievements. In 2013, the Diagnostic and Statistical Manual of Mental Disorders, the 5th version, changed the diagnostic criteria for specific learning disorder to combine all 3 learning disorders, reading, mathematics, and written expression, into one overarching diagnosis. These conditions manifest in specific areas such as reading, known as dyslexia, writing, known as dysgraphia, and math, known as dyscalculia. And this occurs despite the individual having average or above average intelligence. And it's worthy for us to note that the terminology specific learning disorder is used mostly in clinical setting, like clinical diagnosis, as we see. But at times, it can also be called learning disability, mostly used in both educational and legal settings. Legal settings in climes where there are disability laws that protect the interests of these children and give them opportunity for learning. Sometimes it can also be called learning difference, This is a term that has gained popularity, especially when speaking with children about their difficulties, so as not to label them as disordered. Being diagnosed with a learning disorder does not mean that the child is not intelligent. However, getting an accurate diagnosis can make a huge difference for children who are struggling with learning. And with the right instruction, they can thrive in school and beyond and achieve their potentials in life. These disorders, if not recognized and managed, they can cause problems throughout a person's life beyond having low academic achievement. These problems increase risk of greater psychological distress, poorer overall mental health, dropping out of school. A good number of them drop out of school due to poor performance. In adulthood, there will be increased risk of unemployment and underemployment. And specific learning disorders often occur along with other neurodevelopmental disorders, mostly attention deficit hyperactivity disorder and anxiety disorders. How common is this condition? It's known to approximately affect 5 to 15% of school-age children worldwide. And that depends on the diagnostic criteria and population studies, as prevalence varies across the world. Said to be higher in the Western world, lower in Asia, in studies done in Japan and China, though other studies differ. The WHO and UNICEF report that about 240 million children globally live with some form of disability, including learning disabilities. And both databases show that sub-Saharan Africa accounts for a big percentage of these disabilities. Dyslexia is the most common, with prevalence estimates ranging from 5 to 10% globally. In the US alone, 50% of children receiving special services in school have learning disorders. In Nigeria, prevalence estimates for learning disabilities range from 7 to 13% among primary school children, though data is limited and mostly region-specific. Most studies I came across were done in the educational setting among psychologists and special educators. And a study highlights underdiagnosis in our setting due to cultural stigma, limited screening tools, and lack of trained personnel. Because as we'll discover later, we need some screening tools to identify them and place them appropriately. And the problem of validation of tools still plays a role in this limitation. And there is also need for training of personnel to be able to use those tools appropriately. Some studies report that there's no gender discrepancy. However, most others report that it's more frequently diagnosed in boys than in girls, especially dyslexia, to the tune of 2.1 to 3.1 in their ratios. And these symptoms typically emerge between the ages of 5 to 8 when formal education begins. Early signs may be detected in preschools through language delays and poor phonemic awareness. When we notice that these children are not very keen in distinguishing one word and another that sounds similar. What is behind this disorder in terms of pathophysiology? It has been known that it has a neurobiological origin resulting from a combination of genetic and environmental factors that affect how the brain receives, processes, and communicates information. The key factors here include genetic vulnerabilities and atypical brain development. It has been known that some areas of the brain, especially on the left, the dominant hemisphere for language and speech, or the parietal cortex for dyscalculia, demonstrate some structural and neurochemical differences from neurotypical children. So these genetic factors play a substantial role in the etiology of this condition. Twin and family studies have shown heritability. It has been shown that parents who have any of these disorders, their children have an increased chance of having the disorder to the tune of 30 to 70% for various learning disorders. Candidate genes too have been identified and have been shown to be linked to dyslexia and other language-based disorders. There's also a strong environmental influence. Both prenatal and postnatal events can strongly impact brain development and contribute to the development of learning disorders. Some of the prenatal and perinatal factors include low birth weight, prematurity, and the lower the birth weight, the higher the risk. Prenatal exposure to toxins such as alcohol, tobacco, lead, cadmium can also lead to an increased risk. Of course, perinatal asphyxia and birth trauma have also been implicated. Postnatally, CNS infections, both viral and bacterial, have also been implicated. And interestingly, poor early childhood stimulation and children who have adverse childhood experiences also impact their brain development. Malnutrition and limited access to quality education also contribute to delayed cognitive development. So these genetic and developmental factors shape the structure and connectivity of brain networks involved in learning, leading to this disorder. According to the DSM-5, there are 3 types of specific learning disabilities: dyslexia, dysgraphia, and dyscalculia. But the way it is categorized, you have to put specifiers. So for dyslexia, specific learning disability with impairment in reading. For dysgraphia, specific learning disability with impairment in written expression. And for dyscalculia, specific learning disability with impairment in mathematics. Also, the 11th revised International Classification of Diseases refers them as developmental learning disorders, and their own terminology is slightly different. For reading disorder, developmental dyslexia, developmental dyscalculia for math disorder, and developmental dysgraphia for writing disorder. But generally, most developmental pediatricians, their preference depends on this clinical setting and geographic location. Mostly in North America, they use DSM, and in clinical environments, focus on mental health and behavioral disorders, while I see this more preferred in global health systems outside the United States. But we're going to stick for this presentation, we'll stick to DSM-5. Let's look at dyslexia. It's an unexpected difficulty with reading in children who otherwise have the intelligence to learn and read. A specifier with impairment in reading is added to the diagnosis when a person demonstrates significant impairment in one or more of the reading soft skills, including word reading accuracy, reading rate or fluency, decoding, spelling, and or reading comprehension. Children with dyslexia have an unusually difficult time learning to read. So they often struggle with reading new words, sounding out words, recognizing words that they have already learned, spelling and writing. And it's worth to know that it affects both spoken and written language. It's estimated to account for 80% of learning disorders and 20% of the population. In 2019, it was reported that 20% of Nigerians, about 36 million, suffer from this condition. And of course, we know that it starts from childhood. And dyslexia affects males and females equally, according to most studies. The prevalence of this condition in the United States is about 5 to 17%. So it's something that is quite high. And in typical readers, IQ, intelligence quotient, and reading not only track together, but also influence each other over time. But in children with dyslexia, IQ and reading are not linked over time and do not influence one another. So for diagnosis, as we'll later see, you have to assess the child's intelligence quotient and see if there's a discrepancy between that IQ and the child's ability to read. This condition is noted to arise as a result of left hemispheric defect. The planum temporale, a key area for language processing, is said to be involved. And there seems to be an asymmetry in the size and organization of this region of the brain in dyslexic children as compared to their neurotypical peers. So there's reduced activation in the temporoparietal cortex. This is the area of the brain that is involved in word analysis. There's also underactivity in the left occipitotemporal region, a region of the brain that is involved in word formation. So these parts of the brain are part of what is called the posterior systems. They are said to be underdeveloped in children with dyslexia. However, there is a compensatory overactivation on the right hemisphere and in frontal regions, as we'll see in the next slides. So as shown in the slide, the Broca's area, that's area 44 and 45, on both sides is active, but is not as functional in the typical brain, with compensatory increase in size as demonstrated in functional neuroimaging. However, there is deficiency in the posterior aspects, the parietotemporal and the occipitotemporal aspects of the brain. So activities in these areas are not as good in children with dyslexia. This is what I mentioned earlier. If you notice on the dyslexic brain, the size of the inferior frontal gyrus appear to be increased, some form of compensatory mechanism to make up for the reduced function in the normal brain, as in the normal brain. So how do they present? These children present with difficulty matching sounds with letters. They have trouble learning even simple rhymes. Example, cat and bat. They might not be able to rhyme it together. And they seem to achieve speech. They talk later than other children their age. They also have trouble remembering words. They have a hard time following directions. Mostly they leave out little words when reading. Words like they, and, in, or these children also have trouble differentiating left from right when you give them directions. And when they want to wear their shoes, they may have trouble. Hello, can you hear me? Am I being heard?
Yes, we're hearing you. Yes, sir.
Yes, we can hear you.
They have trouble correcting spelling, even familiar words, and they will often spell them phonetically. For instance, when this child wants to mention the word camped, he will spell them. He will spell the word the way it sounds, CMPT, instead of CAMPED. So they lack fluency in reading, continuing to read slowly when other kids are speeding ahead. And they also avoid reading out loud in class. So these signs will be easily identified by the teacher in the class. And they show signs of fatigue from reading with great effort. And beyond the classroom, dyslexia still follows you. A child will have trouble understanding logos and signs, have difficulty learning the rules to games, struggle to remember multi-step directions, have trouble reading clocks and telling time, and have a particular hard time learning a new language. So all this will lead to emotional frustrations, and the child will often throw tantrums due to these challenges. Let's talk about dysgraphia. This is a learning disability that makes it difficult for children to write. An impairment in writing skills is assigned a specifier with impairment in written expression, and refers to those children with impaired spelling and problems with writing that can include difficulties with accuracy, grammar, punctuation, accuracy, and/or clarity, organization of written expression. At the kindergarten age, they have impairment at the kindergarten age, impairment in written expression may not be, a child with this impairment may not be able to recognize and write letters as well as their peers. So it can be identified early enough when a child struggles with writing letters as expected for age. Children who struggle with motor skills may also be given this diagnosis. There are two sides, motor weakness and cognitive challenges. Some children will have both of these, others will have only one. But when it is, most of the time, when the child struggles with only the motor skills involved in writing, we will see that we may also have a diagnosis of dyspraxia in children that are clumsy, but this is slightly different from dysgraphia. Those ones associated as part of differential diagnosis who have other distinguishing features. So what are the signs? Difficulty writing letters, including trouble with forming the letters, spacing them correctly, and making them the same size. So looking at such a child in the early stage, the child will be writing some letters bigger than others and have difficulty spacing them. They will have difficulty holding the pen or the pencil, and they will easily get fatigued when writing. Also difficulty with grammar, punctuation, and sentence structure. So generally, organization and structure in writing is quite a challenge for these children. This calculia, also called mass dyslexia, this refers to a learning disability that makes it hard for children to understand and learn number-based activities. In the DSM-5, this calculia is called specific learning disability with impairment in mathematics. They struggle to understand, learn, and perform math and number-based operations. And the most noticeable sign is that they may perform well in other subjects, such as English, but have very low grades in math. So when a child excels in other aspects, English, history, other aspects of science, but have difficulty in math, we can suspect this disorder. The prevalence is estimated at 5 to 7% in elementary school children, occur equally in genders according to many reports. And it's estimated that a lot of them will have other learning disorders, as you may see. A child may have more than one at the same time. And this is more apparent in the early school years, at around 2nd or 3rd grade. So these skills may be affected in children with dyscalculia. Linguistic skills, understanding terms, operations, and context and concepts. Perceptual skills, recognizing or reading numerical symbols, especially math signs. Attention skills, ability to copy numbers or figures correctly, or remembering to carry numbers when they are doing mathematical operations. Mathematical skills, following steps, counting objects, and being able to recite or memorize the multiplication table. All this will be difficult in these children. So early recognition can be in the young children, difficulty in recognizing numbers, delay in learning to count. This is one of the easiest ones to identify for age. Difficulty recognizing patterns and placing things in order. For the older child, significant difficulty learning basic math functions like addition, subtraction, times table, inability to grasp the concept behind word problems, difficulty estimating distances and how long it will take to complete a task, and difficulty with math homework assignments. This is a child that will often cry over his homework because of the struggle and the effort that he needs to do to progress through. And it also follows you outside school. Math follows you all through your life. So they will have trouble remembering numbers. They will not be able to memorize their phone numbers or that of those that are close to them. They won't be able to follow game scores or remember them. Difficulty counting money, this is the sad part. Making change or estimating how much something will cost. Difficulty judging how long it will take to get from one location to another. And difficulty telling time and reading the clock. So as you can see, the impact is far-reaching and follows you all throughout life. How do we diagnose specific learning disorders? To make this diagnosis, you have to meet 4 criteria. 1, the child must have difficulties in at least one of the following areas for at least 6 months, despite targeted help. Difficulty reading, difficulty understanding the meaning of what is read, difficulty with spelling, difficulty with written expression, difficulty understanding number concepts, difficulty with mathematical reasoning. Also, they must have academic skills that are substantially below what is expected for the child's age and be significant enough to cause problems in school, work, or everyday activities. So this criterion requires that academic skill challenges to be based on standardized achievement measures, as we'll see when we talk about the assessment. So the child's achievement score have to be substantially lower than the child's IQ. The third criterion is that there are difficulties, that these difficulties start during school age, even if some people don't experience any challenges until adulthood, when academic work and day-to-day demands are greater. So it may be subtle earlier on, but when demands of life increases, it becomes more evident. And the final criteria is that the learning difficulties are not due to other conditions such as intellectual disability, visual or hearing impairment, neurological conditions, and other adverse environmental economic disadvantages, not as a result of lack of instruction or difficulties learning or speaking a language. So this all has to be ruled out before this diagnosis can be made. So a diagnosis is made through a combination of observation, interviews, neuropsychological testing, family history. History here is important as we notice that the risk factors include prenatal, postnatal insults, Then there's also need to rule out other medical conditions. We have to be certain that this child is not hearing or visually impaired. In the current DSM-5 classification, specification of the severity is important. It is categorized into mild, moderate, or severe. It's mild when the learning difficulties, there's learning difficulties in one or two academic areas, but the child may be able to compensate with appropriate support services. When it is moderate, there's significant difficulties with learning, requiring some specialized teaching and some accommodation or supportive services in school or in the workplace for adolescents who have passed into adulthood. Severity, it becomes severe when there's the severe difficulties with learning affecting several academic areas and requiring ongoing intensive specialized teaching for most of the school years. So in this category, even with accommodations, an individual with severe SLD may not be able to perform academic tasks with efficiency. So this severity criteria also helps to know the degree of support the child will need. So these support services align with severity to facilitate a person's most effective functioning in management. How do we evaluate these children and this condition? Pediatricians are often the first point of contact for identifying learning concerns when they are identified in school or at home. Beyond when they are identified in school or at home, we can identify them doing routine visits when we monitor language, motor, and cognitive milestones, and also by engaging parents about school performance and behavior. So by the time we detect some of these subtle signs, even before formal schooling, so pediatricians can play a huge role as to see later. There are screening tools that can be used to identify these challenges before thorough evaluation. The Denver tool for children before 6 years, it screens developmental delays in language, apart from gross motor domains. Then the strengths and difficulties questionnaire also plays a role. Most importantly, teacher reports. These provide classroom-based observations in real time when they observe these children, their academic performance, their interaction with their peers. So for those that red flags have been identified, they will need further psychoeducational testing. And these red flags include academic struggles, persistent academic struggles despite normal intelligence, teachers' reports, and the screening tools. For more detailed evaluation, these children will need a model that will compare the child's intellectual potential with the actual academic performance. So a significant difference between what is expected and the actual achievement may indicate learning disability. It has been identified that IQ tests correlate with and predict school achievement and measure of academic intelligence. And IQ tests are relatively stable and not unchanging. Disability increases with age. We also know that it's not free from cultural influences. So there needs to be adaptation of the tools you also use. But it may fail to measure other factors. But for these children, identifying the IQ and academic achievements will know if there's a discrepancy. So the psychoeducational testing will assess cognitive ability, academic achievements, language, and executive functions. The cognitive and intelligence test we rely on tools like the Wechsler Intelligence Scale for children. Currently, we have the 4th version, and depending on the age, the 3rd version is for children 2.6 to 7.3 years. The 4th version is for children between 6 and 16 years. You can also have others like Stanford Binet Intelligence Scales, Hoffman Assessment Battery for children, and for nonverbal intelligence, Raven's Progressive Matrices. The achievement tests that can be used include Stanford Achievement Test, California Achievement Test, individually administered test, wide range achievement test. This test of specific cognitive tasks has proved to be useful in analyzing specific cognitive deficits to find potential targets of intervention for cognitive compensation. Other assessments include language and communication assessments. These are the ones usually used by those in education sector, special educators. A lot of them have been validated in Nigeria, especially the screener for reading and writing tool and the learning disability checklist. So they can be used to identify children at risk. Now, the management team is multidisciplinary. Involves the parents playing a crucial role in providing insight to the child's behavior, history, and the home environment. The teachers and special educators are there to implement individualized educational plans, monitor progress, and also adjust their teaching methods. School psychologists provide and conduct cognitive and behavioral assessment to help to make this diagnosis. Speech and language therapists address language-based issues like and help to improve communication skills essential for academic success. Occupational therapists will assist and support physical and cognitive readiness for learning. Especially they assist with fine motor skills, sensory integration, and executive functioning. Clinical psychologists also play a role to diagnose and treat co-occurring emotional and behavioral issues. Child psychiatrists also play a role in this. They play an art therapist, as we see later, facilitate self-expression and assist child in managing behaviors. For the medical professionals, the pediatricians, the pediatric neurologists will play a central role, roll out other medical courses, and prescribe medications too when needed, especially for occurring comorbidities. So we provide the broader health context for learning challenges. Pediatricians play a central role. I want to say one or two things about these key functions we play as pediatricians. Early identification is very important. So our key responsibilities will be in monitoring developmental milestones, using the screening tools, listening to parental concerns and teacher reports, and referring early. Need to involve the other specialists in the team when we see red flags. Then we'll also coordinate, play a coordinating role. We'll serve as the central point of contact in this multidisciplinary team, ensuring timely referrals and facilitating communication between families, schools, teachers, and the other health professionals. And also support the families by educating the parents about the nature of the disabilities, address parental concerns, reduce stigma, and promote realistic expectations. We also collaborate with schools, with educators to support classroom accommodations and behavioral strategies that need to be put in place to make sure that these children respond to interventions in the appropriate settings. And also encourage follow-up to track academic, emotional, and social development. What are the outcomes Usually, the prognosis of this condition depends on the disorder. When it's dyslexia, there's a poorer outcome than when it is non-verbal, like dysgraphia. Timely diagnosis is essential. The earlier is diagnosed and intervention instituted, the better the prognosis. Higher IQ is also associated with better compensation and better outcome. Access to quality education, therapy, and parental involvement also improves prognosis. So when this access is there, it assures earlier intervention. Parental involvement also plays a central role, as I mentioned earlier, and this also contributes to our prognosis. It has also been noted that presence of other comorbidities complicates the management and affects prognosis. And of course, we know there are no approved medications for the specific learning disorders. The medications will only be for their comorbidities when applicable. And this condition is lifelong. So the time of diagnosis, IQ, and presence of comorbidities complicates the outcome. The common differential diagnosis for this condition include intellectual disability, and of course, intellectual disability. In intellectual disability, there is a global deficit in intellectual function and adaptive behavior, while in specific learning disorders affect specific academic skills and overall intelligence typically average or above. For auditory sensory processing disorder, those with auditory sensory processing disorder have problem with functional hearing. They hear well with no physical impairment. They have difficulty receiving this information accurately. And this disorder is associated with inability of the brain to correctly interpret and understand and follow and remember oral instructions. This is not what is found in specific learning disabilities. For dyspraxia, a condition that causes children to appear clumsy, uncoordinated compared to other kids. They may have poor motor skills, they may walk late, have difficulty balancing, and this is one of the things that typically distinguishes it from dysgraphia. Those with dysgraphia may have difficulty writing, but generally in other aspects of life, they are not clumsy. Of course, the global developmental delay, there's slower achievement of developmental milestones across all domains. Then sensory impairments like hearing or visual loss, of course, affect learning indirectly. While in children with SLD, it occurs despite normal sensory function. It's also important to mention non-verbal learning disorder. This occurs in individuals who have trouble recognizing and understanding patterns in body language, visual, spatial information, and other kinds of non-verbal communication. These children are often good with words, but struggle in social situations. So sometimes they are often misdiagnosed as autism spectrum disorder or ADHD, but they are not specific learning disorders. So in conclusion, this condition is lifelong and adversely impacts function and achievement. For the success of a child with this disorder, early identification and effective intervention is imperative. Children with these learning disabilities often present with non-specific complaints, school performance, low self-esteem, behavioral issues that will be traced eventually to specific learning disabilities. Pediatricians should maintain a high index of suspicion and get used to frequently using structured tools to guide their decision-making so that we don't miss out on these children when they present to us. We should also be able to identify these disorders and liaise with other specialists. Educators and families play a central role, must be aware of the warning signs of language and communication disabilities. And this is where we come in as PAN. There's urgent need for advocacy. A lot of our educational facilities do not have special teachers that will be able to identify these challenges. Every classroom teacher should be trained on how to identify learning disabilities in children. There's also a need for us to play a more role and come out more stronger to ensure that there are legislations to address the needs and protect the interests of children with learning disabilities. I know in Nigeria, we are signatory to the Disability Act, and it has not been well domiciled in Nigeria and in many states. So PAN needs to play a stronger role to advocate for these children. We may be the only voice they will have to achieve their potentials. They may be the only voice we'll have for the government to put in place the infrastructure and the manpower to be able to train these children and give them a chance of becoming independent and impact themselves positively and their environment and live out their full potentials in adulthood. I want to thank all of us for listening and appreciate this opportunity provided by PAN and the CHILD NEUROLOGY Society. I want to thank especially my president, Professor Esegbe. I want to sincerely also thank my father and mentor, Professor Asindi, my colleagues in Calabar, and also Dr. Victor Kopo and Dr. Osim, my close ICT pals. Thank you very much for listening.
Thank you very much, Dr. Totti, for that brilliant presentation. Without further ado, I'll invite the next speaker, Lamin Gidado, to make her presentation. Lamin?
Good afternoon, everyone. I just want to confirm that you can hear me.
Yes, we can.
Okay.
Yes, I can hear you.
Thank you so much, and thank you for having me. I will be talking about the identification and therapeutic interventions for childhood learning disabilities. I am a play therapist, and so the objective today, I would like to tell you about the work that we do at Cluster for Kids and the children that we care for and how we identify these children, and then talk about the therapeutic interventions that we use, the effectiveness of the interventions, best practices, the importance of therapeutic play in interventions for children with learning disabilities, procedures for working with children with learning disabilities, and working with parents. So like I said, I run the center called Cluster for Kids in Jos. It's an early learning center, and we work with children ages 0 to 8 years using the play-based curriculum. And we also provide therapeutic play interventions. So we started the center in 2014 with my son as the first student. Before then, he was attending a nursery school where, the teachers were frustrated because they had been teaching the ABCs for a long time and he wasn't learning. And so I withdrew him from school because one day I went to school to pick him up and I was told that the teacher beat him on the hand because she thought he was lazy. So I decided to homeschool him using a play-based curriculum, and within 2 weeks, he mastered what they had tried to teach him for a year. We currently have 90 students, mostly neurotypical children, with about 15% with learning disabilities. We have a special room called the sensory room where the children, they learn differently. And so what we do is that we have about 5 of these children are in the mainstream classrooms. And in the sensory room, we have a ratio of 1 teacher to 3 children. And each child is given one-on-one sessions because, we individualize their learning. There are many other group activities such as, we have devotion time and circle time, arts, and many other activities. They also have educational and play therapy sessions with qualified therapists. Some of the children in the classrooms have shadow teacher who is employed specifically to care for them. And most of the children that we have are referred to us by doctors and the parents of other children that already attend our center. So how do we identify these children? One of the first things that we do when they come to us is to ask if they have been seen by a doctor, because we want to rule out medical issues and we want diagnosis by a doctor. So we also want to get an assessment done. And at our center, we work with a child neurologist and a psychologist to carry out a thorough evaluation. We also carry out observational assessments for about 3 hours by providing play opportunities for the child. Even after we have admitted children, we have, we have seen that other issues tend to surface as the child settles into school. And so we keep a learning journal where we record patterns that reoccur in their play. We also use the developmental milestone checklist from the Center for Disease Control website, and we do that twice a year. So after 2 months into the school session, we use the developmental checklist, and about 2 months before the end of the school year also. We use the strength and difficulty questionnaire filled out by the parents and the teachers. And sometimes if the child is old enough, we also have the child fill one of the questionnaires. So we do this before we start play therapy and also at the end of the school year. Play therapy helps with the emotional and behavioral issues such as self-esteem, emotional dysregulation, hyperactivity, anxiety issues. And then we use the search and teach educational therapy as well to find out where the child has learning gaps, because they usually do. And that deals with the academic issues. The search and teach is an early intervention program developed by the National Institute for Learning Development in the US. And then lastly, we look at the teacher's assessment of the child. At our center, for example, assessments are carried out daily and recorded in an app called Illumine, where parents can also see their child's progress and make comments. Sometimes the teachers include pictures and short videos, whatever is necessary for parents to see the progress of their children. So like I've mentioned, we provide educational therapy by using toolkits, play therapy, and this is because almost always children with learning disabilities are dealing with emotional and behavioral difficulties because of the stigma, the misunderstanding of their condition. They deal with issues such as exclusion from school, exclusion from activities, neglect, fear of being asked to read or solve a math problem in front of the whole class. Sometimes they are the children who are labeled as lazy, stubborn, disruptive, naughty. And in some cases, the child may need speech and language therapy. It's quite challenging for us, especially in JOS. And right now, I know only one speech and language therapist in JOS. And then one of the things that we have focused on recently is empowering parents and shadow teachers through our playful intervention training program and other awareness programs. What is the effectiveness of the therapeutic interventions that we carry out? Records from Play Therapy International show that 77 to 80% of children who receive play therapy worldwide show positive changes. And in Nigeria, based on records from the Association of Play Therapy, 90% who receive play therapy, along with other interventions like the educational therapy, show improvement in all areas of development. So when combined with other interventions, there's faster integration into the mainstream classroom. We also get feedback from parents, especially concerning behavioral challenges. And also the learning journals that we keep shows patterns of improvement. We also just continue to use the SDQ to check for improvement. For those of us who work with children and manage children with learning disabilities, there are best practices. One is mode of communication. Children seem to communicate to whatever way is easiest for them. So as caregivers, we can support a child's communication by using multiple methods, including speaking and pointing and gestures, pictures, and accepting those as a way of communicating. So we want to be able to have a combination of verbal and non-verbal communication methods. Whether the child can speak or not, it's still going to be beneficial for all children. We also consider the child's learning styles. Some people learn best visually or when they see or watch something. Others learn best when information is presented auditory or hearing or listening, while others learn best when learning is kinesthetic or involves movement and action. So every child is different and responds differently to each mode of learning. And there's none that is right or wrong. They're just different. So the more learning styles a teacher or caregiver uses, the greater the understanding the children will have. So, for example, when we want to read a book maybe about or do an activity about rainbows, we may do a visual activity, like have a picture of a rainbow, and an auditory activity would be listening to the caregiver talk about rainbows. And a kinesthetic activity would be coloring a picture of a rainbow or making rainbow with some cardboard or other resources, other materials, recyclable materials. So the most effective activity will be doing all three strategies together. You show pictures while you explain, and then you have the children make their own rainbows. It takes effort, and I know that teachers often complain about the volume of their work, but it has huge impact at the end of the day. Then best and appropriate relationships is important. If a child has a positive and trusting relationship with the caregiver, they will feel more comfortable to share things going on. things that are difficult, and they will be more open in general. If the relationship is based on fear or punishment or them trying to avoid doing something wrong, they may find they may be successful, or it may look like they're successful, but usually things will be more difficult later on. If a teacher is working towards building positive relationship, spend time doing something together, listen to them, and find out what they like and don't like, a little bit of effort in getting to know them will go a long way. Even children who do not have vocabulary will communicate their needs and preferences through sounds and gestures. Then there's proximity, and this is about how close you are, how close your body is in relation to another person. So the closer you are physically to a child, their level of awareness will increase. Another example is, instead of calling for a child from across the room, standing in front of the class and calling for the child in front of from the front of the room, you will have better results by coming close to the child. And it is the same if a child is talking in class and you want to have them keep quiet, right? So moving closer to the child rather than just shouting and telling them to keep quiet, but coming close to them will be more impactful. And then consistent routine and schedule. When children have clear and consistent schedule, it reduces their anxiety and it provides structure. Many children with disability have, they have much success in completing tasks and functioning throughout the day when they know what is expected of them. It makes them feel safe when they know, what is coming next. So it is helpful to write down in words or have a schedule with pictures so the child can follow along their schedule successfully. It's also important to know and understand the children's needs and interests. When we are actively engaging our children, we have more opportunities for success. So, for example, we had a child who loved Spider-Man. So we provided red and blue counters, books, storybooks, to fit his interest, and that caught his attention, and that was the beginning of learning for him. Collaborations are important. We believe that partnerships with multisensory team is very beneficial, and so we engage other professionals in our work. And then using an individualized educational plan is also important because we set achievable goals for each child with the team and with the parent. So we work with them, and then we return the next month to create another individualized plan. So what is the importance of therapeutic play in managing childhood learning disabilities? Like I said, we use most of the interventions that we use are, through therapeutic play. So play causes neuroplasticity to happen because children are recording new experiences during play, which then would strengthen and create new neural pathways. It also allows children to adapt as they play. And they record positive experiences. For example, nurturing relationships with their caregivers, like I mentioned earlier, stimulating environments and opportunities to learn through play stimulates their brain. And if this is something that is done regularly, then their brain is wiring for the right reason. So their brains adapt by developing healthy coping mechanisms, building resilience, enhancing cognitive and emotional abilities. So play provides opportunities for repeated experiences. And so through play with their caregivers, children feel loved, and this helps them to develop self-regulation skills, as many of the children that we work with are usually dysregulated, and we need to work on the behavior before they can learn. Yeah, so which means at the end of the day that they will be developing skills. And then also play calms the amygdala. Children with disabilities are more likely to have unhealthy coping skills because they are so used to protecting themselves. And so if the amygdala is activated, talking at that point is no use because the brain is in protective mode. Play helps them to calm down. And when the child's brain is in protective mode, what we see as caregivers comes out as unwanted behavior, and they end up getting labeled unfairly as stubborn or troublesome, and all of those labels that we give children. And then also play aids in the release of the feel-good hormones like oxytocin and endorphins and dopamine, so they get the motivation to continue to learn. And then also play can be used as an assessment tool in and of itself, because from observing children, we're able to record what the experiences that they are having. Sorry. And I think the last one is that it is age and developmentally appropriate. Okay, so working with parents should be a must when managing children with disabilities. Studies have shown that disability diagnosis evokes a range of parental, emotional, and adaptive responses, including mental health difficulties and financial problems and domestic violence. When we meet with parents, we need to be empathetic listeners. We also provide psychoeducational support through trainings. And it is important to plan with them so that whatever we're doing in school is done at home as well. And also to give the parent a sense of responsibility. We also encourage parents to be advocates for their children until they're old enough to advocate for themselves. Sometimes when they change classes, the parent needs to ensure that the new teacher has all the information required to help the child to settle in. And lastly, we must be non-judgmental practitioners. Parents have, they already have feelings of guilt, of shame, anxiety, and many more feelings, and we don't want to add to their trauma. So the procedures for working with children with disabilities, we interview the parents and get as much information as we can. And then we gather information. We want to know the medical history of the child and other settings that the child has attended, and get information from that setting, and also the reason why they're leaving that other setting to come to us. And then we have the initial assessments. I already mentioned some of the assessments that we carry out. And then we then admit the child, or we refer them elsewhere. So our center caters for children with mild to moderate cases. And then there's a setting that deals with severe cases where we refer children to. And then there's the observational assessments and progress reporting. And then finally, we review, sometimes depending on the type of, the severity of the situation, we have monthly reviews, and sometimes they are quarterly reviews. And then we continue with the, IEPs. So in conclusion, children should be thoroughly assessed. That is important, with recommendations and all of that given. And also just to rule out medical issues.
It's close. I can see.
To rule out eye issues and hearing and all of that. And then identification and management of children with learning disability needs specialized training. And it is also important to work with parents and other professionals. And then finally, we can, direct people to seek for help through the Thank you for having me speak. Thank you to Professor Esebe for the honor that I've received to speak to all of us today. Thank you.
Thank you, Lamin Gidado. I want to thank the two speakers. Their presentations have been brilliant, and I'm sure we have questions or comments to make. So at this juncture,
but we have
if we have
13 minutes more.
Yes, I know. We just take one or two comments or questions. You can indicate by raising your electronic hand, and we'll take them.
Can I ask a question?
Please go ahead. Please go ahead.
Okay. Thank you so much for this very nice presentation. Very enlightening. For Dr. Totti, in the beginning, you said that there are actually anatomic differences in the either parietal, temporal area for children with learning disability. I want to know if you came across any study, especially in the Western world, where they've put a lot of resources to it, where after where they followed these children through, maybe successfully, they became neurotypical into adulthood. They re-imaged and found out that it's now normalized. I'm just wondering about it. Or what is do you find any long-term study of the outcome of these children in adulthood? Those ones that had interventions that were considered successful.
So, Dr. Totti, please kindly respond to that quickly.
Thank you very much for the question. I think that's a brilliant one. Candidly, those structural and functional abnormalities that have been noted, I did not come across any specific study of follow-up to know if they resolved. I may not have all the answers, but it's also good to know that beyond the functional neuroimaging, even before their advent, even autopsy findings have shown cytoarchitectural changes in these areas of the brain that I mentioned. I don't know any study that has followed up these children over time to know if there's any. We know that there's a neuroplasticity, especially if these children is improvement in their symptoms. Definitely, if you do a neuroimaging, especially functional neuroimaging, you should be able to highlight some of those areas that activity has improved. I might not know about structurally, but functionally, at the time you do neuroimaging, to be able to highlight some of those areas that were quiescent in the posterior system, of course, due to some improvements in the way the child writes or reads. That means improved connectivity in these areas it should highlight. I think that's a good question to answer. I will also check it up. But I strongly believe with improvement connectivity, plasticity with intervention and learning, neurofunctional neuroimages should highlight some changes in those areas that were previously not as functional in neurotypical children. Thank you.
Thank you
very much, Dr. Totti. Thank you for the question. Any other question or comment?
Yes, my hand has been up, sir.
Okay, please go ahead. Please go ahead.
All right, thank you very much. I want to thank the presenters, Dr. Totti, Dr. Lamido, for a very good presentation. But mine is more of a comment. I know that when Dr. Totti was presenting, he said the pediatricians are usually the first point of call, if I heard him very correct. Well, I keep wondering if they are really, because if I understand that statement, because I feel that this learning disability, most times, it may even come to us late, and sometimes we lack the capacity. But thank God for this training. I mean, this seminar, we're able to also have some increase in at least in depth in suspecting such disorders. But I feel that the parents and the teachers, like somebody, I think it was stressed later, we need to increase awareness amongst them. Because the parents, they are the ones that hold these children. It's part of the child milestones. And if there is a way, we as an association can also raise this awareness and let them know the signs, the features, then they can be able to present early to the health facility. Then, secondly, when they present to us, I must say that we have limited capacity to intervene effectively. I mean, taking from what we see, the few I come across, I'm not a neurologist, I'm a pediatrician, quite all right. And then sometimes some people come to me because their children have problems with schools. Sometimes speech therapy is what they need. And we lack the manpower. Sometimes I have to refer them as far as Lagos and some other places like that. And I wish something can really be done, because it's not just enough to make the diagnosis. What then can we do afterwards? We need manpower. We need the facilities to be able to intervene effectively when we catch them early. So thank you very much. Mine is simply a comment, and I appreciate this presentation today. Thanks to the presenters, thanks to Pan. Thank you.
Thank you very much. I will just round up by saying the last speaker just captured everything, early diagnosis, and then what next? What do we do next? We are thankful to PAN for this platform. What we can only do is to continue with advocacy, encourage programs like this, increase awareness by advocating for the rights and privileges of children with special needs, and encouraging many young doctors and many young healthcare providers to embrace the vast field of special needs. The Child Neurology Society of Nigeria is available. Doctors, including pediatricians, can make contact with society as we continue to spread the gospel and develop capacity in this end. Let me join everyone in thanking the Neurology Society of Nigeria, this platform, to espouse this particularly concerning topic. And my special gratitude to the speakers, Dr. Totti and Mrs. Girado. Thank you all. God bless you all. Over to Pan.
Wow, thank you very much, Dr. Isegwe and the Child Neurological Society of Nigeria for putting up this interesting and very enlightening topic. I can see that we still have some few hands up, but because of time, I'm sure we can reach Dr. Totti or Mrs. Lamy directly. The slides will be shared. Pan puts it in our WhatsApp group for those who wish to go through it again. I'd like to thank everybody for coming and listening. And I'll say we'll see again next month for another nice session. Thank you, everyone.
Thank you.
Thank you so much.
My question.
Thank you, everyone.
Is that Tewase?
Yes, ma'am.
What is it?
I had a question. I was raising up my hands. It's just a brief
The
question.
session is over, but the speakers are still here, so maybe.
Okay. My own question was like, thank you, Dr. Totti, for the insightful presentation, Dr. Mrs. Lamy. I really learned a lot. I wanted to ask a question. Apart from these academic achievement tests we used to access learning disabilities, how readily available are these other tests, other tools you mentioned? Like you talked about the Wechsler intelligence skill, the Stanford Binet skill, and Raven. How readily available are these skills, these screening tools?
Thank you very much for your question. These tools are not readily available, that's the truth. Most of them, you need to pay for them. However, a few of them have been validated for use in children in Nigeria, especially among the psychologists and educationists. The SDQ, the early reader screener, and the disability checklist, they have been validated for use in Nigeria. Mostly, they are used to do screening in the educational setting and also in clinic settings. So one of the things this presentation achieves is creating awareness, even among pediatricians and neurologists, that some of these tools, we can use them. But for the other ones, Wechsler, Binet, Stanford, most of these other ones, I'm not certain. They have been adapted for use, but not validated. You know, most of these tools have cultural bias because they were used in Western cultures. But I know a few studies to have used them among Nigerian children. And good enough, there are other tools that have been homegrown. The Ibadan ISBS, the Ibadan Developmental Screening Tool, developed by Professor Lagunjo and co. So this one is usually for motor milestones, but we hope that in the future, it's also a challenge to all of us. Make homegrown products for use by Nigerian doctors. I'm also aware for autism, the Nigerian Autism Screening Questionnaire have also been developed in Nigeria by a child psychiatrist and his colleagues. So there's a light in the tunnel, but the broader view, we are still behind. Availability and accessibility is a problem. These things are sold in dollars, but the few that are available, we can avail ourselves of the opportunity to use them. Thank you.
Thank you, sir.
Dr. Totti. Okay, I guess that's it then. Tewase, I hope you're okay now.
Yes, I am, ma'am. Thank you very much, ma'am.
Okay. Problem.
Now, the reason why I asked this question is because we have a school of learning, a school for special needs in Bisut now. So I was just thinking of even like my research or my proposal topics on something like this also. So
you can reach out.
Okay, yes, sir. Right. Okay, sir. I don't know. Maybe I'll have your number.
Yes, you can contact the PAN secretary so that we can close this platform.
All right. Thank you very much.
I hope you have the secretary's number, Dr. Tewase.
No, I don't.
We're catching you now. You have to come to Abeokuta.
Abeokuta.
Yes, for Pankoff.
No worry, I'll be there, ma.
Okay, no wahala.
Thank you, ma.
Thank you so much, Dr. Isegbe and team. So simply awesome.
Please, is it possible to get this
the recording will be
recording?
shared. Yes, it will be shared on the PAN platform by the secretary.
Okay, no, I'm not a member of PAN. I
Oh,
was invited by Mrs. Gidado to be part
okay.
of this. I'm in Lagos. No, this is Gabriel. I live in Lagos and I work with children with special needs. I'm a teacher.
Oh, okay. So give me your number so that I can give to the secretary.
Okay, can I just give you it now? Yes.
Yes,
080
yes.
97 99 99 again 77
08097999977. Special number.
Yes.
You say is who?
My name is Gabriel. I work in Lagos. I live and work in Lagos with children with special needs.
Okay. I'll send to her. She'll send to your WhatsApp.
Okay. Thank you very much.
Thank you, sir.
You have my number.
No, I want you to come to Abeokuta.
I'll come.
Are you not on the Power platform?
Not yet.
That means you haven't joined, though. Yeah?
That's why you need to have my WhatsApp number so that I will join now.
Okay.
Hello, ma'am. Good evening, ma'am.
Good evening.
Please, this is Liam Bay. Please, I dropped my number on the WhatsApp. I don't know if I'll be added on the Pan Africa or sent to the